Okay, great. So thanks so much for the opportunity to talk. There might be people in the audience better qualified to talk about RSV than me, but I'll give you an update from my perspective. And I think, well, an hour is quite a long time. So what I've tried to do is cover a few different areas. I've got 45 slides, so I'm hoping that there'll be time at the end for questions and discussion. But I'm very open to discuss or take questions whenever. I'm not sure how the chairs feel. So just a bit of an overview. No, it's not doing anything. Sorry, there. In terms of what I'm going to cover, I'll start off with a bit about burden of disease. And Jeremy indicated that there's a mix here of adult and pediatric clinicians. So obviously RSV is generally seen as mostly a pediatric disease, but there is a recent increase in interest in adult disease. So I've got a little bit about adult disease as well. I've got a few slides about some of our less clinically relevant work, but sort of more underlying dynamics work on burden of disease and transmission in South Africa. And then this whole second half will really be about the new interventions that are available, and a little bit of thinking around those interventions, mostly focused on the public sector in South Africa. And then just to end off, I've got a few slides from our sentinel surveillance at the NICD to tell you what's happening with RSV right now. And I'm not sure why this thing is really not. Okay, so burden of disease in children. And just to start off with, this is a study published in OFID in 2023. And I really just chose it as an exemplar of really thousands and thousands of studies out there. It's a study looking at respiratory illness in children in low and middle income countries. And it's one of those studies where they enrolled lots of children with low respiratory tract infection, and they tested them all on PCR for a range of pathogens, viral and bacterial, and then they enrolled healthy controls and they compared. And really what you see overwhelmingly at all these sites is that RSV comes out the top pathogen. And basically, whether you're in a high income country, a low income country, anywhere in the world, where you look at young children with low respiratory tract infection, RSV will invariably dominate. And it's not only that it's the commonest, it's sort of substantially several-fold more common typically than other pathogens. So really, I think the importance of RSV is unquestionable. This is the latest burden of disease study from Harish Nair's group in Edinburgh. They update these estimates every couple of years. And you can see here they estimate ALRI, about 33 million episodes in young kids, hospitalizations, 3.5 million hospitalizations, and substantial mortality as well. 26,000 deaths in children less than 5 years old. I think the really important thing to note is that overwhelmingly these deaths are occurring in low and middle income countries. So 97% of all deaths in low and middle income countries. And that's really important when we come to talk about the interventions, which of course are already being used in high income countries, which is not where the deaths are occurring. And these deaths are also, and hospitalizations, so severe endpoints, are concentrated in young children under the age of 6 months. I'll show you a little bit more of that a little later. And then really important is the fact that when we look at severe outcomes, so low respiratory tract infection and hospitalizations, there really is a very big burden of this that occurs outside of the hospital. And a little later, I'll show you the data for South Africa, but here you can see the global estimates. So for example, in children less than 6 months, there are about 13,000 in-hospital deaths that they estimate, but 45,000 overall deaths. So in low and middle income countries, these deaths are overwhelmingly occurring outside of the hospitals. So although, and I'm sure some of you pediatricians, even now, although the season's coming down a bit, your ICUs are probably full of babies with RSV right now. There's probably a lot of kids out there that aren't reaching hospital, and we and adults. I'll show you that later. And we do see amongst the sudden unexplained deaths that do come to us at NICD. We had one, in fact, this week, a 6-week-old child who died of RSV, and never reached the hospital. So I think it really, and of course, these kids that don't get to hospital, there's no way to impact them except with something like vaccination that would prevent the whole cascade of events, because they're not even coming to you for you to have the chance of treating them. If we look at the age distribution of RSV cases, and this is focusing on children. This is a US, this is data from the United States, a typical high-income country, and you can see while the disease is really concentrated in young kids, the peak age is really at about one month of age. So the kids in the first month they have a lower incidence, peaks at 1 month, and then it drops. And if you compare that to South Africa, you can see in South Africa we have quite a similar picture, although even in the first month of life, we really are seeing a very high burden of RSV. And in fact, if you actually take those numbers and compare sort of the left skewing or the concentration of severe RSV in the youngest ages, and in our study, I'm showing you South Africa data, but we also looked at Kenya, another low middle income country with good data on RSV. You see that in countries in Africa, anyway, our disease is even more left skewed to the youngest ages. And that's really important because the interventions, which we'll discuss a little bit later, really only work in young kids, and they last just for the first few months of life. So the fact that so much severe disease is really in the very first months of life is good for these interventions, because it suggests that in our kind of a setting, these interventions could have a greater impact, because so much of our disease is in really young kids. And I'll just change to this is the same data for South Africa, but now just showing you not only the hospitalizations, which is in the middle, that was the graph I showed you before, but showing you the different severity endpoints for South Africa. So on the left, you have mild disease or outpatient disease. So these are children presenting to clinics with RSV, and those are the rates by age group in months. Then in the middle, you have the hospitalized illness, and then on the right, you have the mortality. And just to highlight that left skewing to the youngest age is concentrated in the severe outcomes, so hospitalized and deaths. If you look at the mild disease, it's much more spread across the different age groups, but obviously of less public health importance. And for all endpoints, just to highlight that there is a burden of out-of-hospital. So the blue in that right-hand death graph, the blue is the out-of-hospital, the red is the in-hospital. And you can see there is a fair burden, even in South Africa, of out-of-hospital mortality. And we estimate that there's about 592 RSV-associated deaths each year in South Africa in the first year of life. So this is just to highlight what I mentioned, that there is a burden of out-of-hospital deaths. For children, it's about 1 in 4 RSV-associated deaths that we estimate out of hospital in South Africa. This is quite different from the rest of Africa. In other parts of Africa, it's much more, about 2/3 of RSV deaths would occur in the community. But in South Africa, I think young children have relatively better access to hospital care, and also they have free care. Interestingly, when we look in adults, and I'm going to focus on adults a little later, about half of all adult deaths associated with RSV actually occur outside of the hospital. So there's quite a substantial burden of out-of-hospital RSV-associated mortality in adults in South Africa as well, as a proportion of all RSV-associated deaths. And then just lastly, for the kids, just to show you risk factors. I'm sure many of you will be familiar with the risk factors for RSV hospitalization, but this is South African data. So young age is overwhelmingly the highest risk factor. The younger the child, the higher they are at risk of hospitalization. Then prematurity is probably the most commonly known established risk factor, and in our study we confirmed that it is an important risk factor in South Africa as well. HIV infection is very important, and it's not on the slide, but HIV exposure. There are not a lot of studies on HIV exposure, but we have published, I think, 2 papers that show that HIV exposure is associated with an increased risk of RSV-associated hospitalization. Not as high as for HIV, So you can see HIV is 22 times greater. So HIV exposure would be more like a doubling of your risk of hospitalization. Very little data on malnutrition, but you can see here in this study, we did show that malnutrition is a risk factor for hospitalization. And then, many of your other underlying illnesses, especially cardiac and lung disease, would be risk factors. But those are more sort of general, not so much specific to South Africa. In terms of adults, just one group which has been quite well studied, although they're not really a high-risk group for RSV, is pregnant individuals. So I just have one slide here to really show that while there is a burden of RSV amongst pregnant individuals, it's really not a high burden. So RSV is a relatively minor contributor to respiratory illness in pregnant women. Obviously, the reason there are so many studies is because in the maternal vaccine studies, in those clinical trials, they typically test these patients for RSV, and then there's been a number of other studies driven by the availability of maternal vaccines. But I think in contrast to influenza, we know for influenza, pregnant women themselves have a much higher risk of hospitalization for flu. And so when you give the vaccine to pregnant women, you benefit both the mom and the baby. For RSV, I think it's not really the same. Pregnant women on their own really don't have a much greater risk of hospitalization. And so the benefit is really mostly conferred upon the baby when you vaccinate pregnant women. But on the other hand, the risk or burden of RSV in her baby is much higher than for flu. So the potential benefit to the baby is, of course, much greater. Just looking at age, so in adults as in young kids, age is overwhelmingly the strongest risk factor. And you can see this is data from the United States, just showing that increasing age is substantially associated with an increased incidence of severe RSV. And then this is just data on underlying illnesses in adults, and you can see lung disease, heart disease, diabetes, cancer, kidney disease. So the traditional comorbidities that put you at risk more generally of respiratory disease and pneumonia would be similar in adults for RSV. And then just I put this up for interest, although I'm not, it's quite a nascent area of study. And there have been a number of recent studies looking at RSV in adults and looking at different diagnostic approaches. The classic way to diagnose RSV would be a PCR from a nasopharyngeal swab. But recently, people have been investigating other specimen types like saliva, like serology, like sputum, and you can see from these Venn diagrams that there does seem to be evidence that the more you look for it, or the more samples you take, the more RSV you will find. And I think a lot of these studies have been driven by the availability of RSV vaccines in the elderly, and therefore the desire to demonstrate that there is a burden or a substantial burden of RSV in the elderly. A number of these studies have been funded by industry, and so I think, and there haven't been that many yet. So that's why I say I have a little bit of caution about these data, but I do think it's something we need to look at going forward, especially as these interventions become available. And if we do think there is a clinical reason why we want to diagnose RSV in the elderly, that maybe we need to take more samples if we want to increase the yield. Just one slide from South Africa in terms of the burden of RSV in adults. And this is a graph that in fact is showing the burden of RSV across the life course. So the y-axis is the incidence rate per 100,000 population, and on the left you have influenza-like illness, and on the right you have this, severe respiratory illness, so hospitalized. The red line is hospitalized people with lower respiratory tract infection. And the x-axis is your different age groups from less than 1 year up to greater than 65 years. And if you look at that red graph, you do see that the incidence is going up there in the elderly. Maybe if you've got a big enough screen, you'll see it. But I just wanted to show you to highlight that while there is an increased incidence of RSV in the elderly in South Africa, and it is a contributor to severe respiratory illness, it is orders of magnitude lower than the burden in young children. So their burden in young children is well over 10 times much greater than the burden in the elderly. And this is the reason why in South Africa, when I get to the public health case for RSV vaccination, I'm really going to focus on children. I do think that if resources are not an issue, and if these products become available, there may be a place for RSV vaccine in adults in South Africa. But from a public health perspective, in terms of overall impact, I think this graph really brings it through that really the place we need to be focusing is young kids for this disease in terms of burden in South Africa, at least. This is my second last slide on adults, just to show you the risk factors in adults. Again, this is local data. As in children, age is overwhelmingly most important. So the older you are, the more likely you are to end up in hospital for RSV. And then underlying illnesses, so HIV, and then a range of respiratory and cardiac underlying illnesses also place you at increased risk of hospitalization for RSV. I think the one data, you may not be familiar with is the HIV data, because there are not that many studies that actually look at HIV as a risk factor for severe RSV. But as with almost every respiratory pathogen, HIV is a risk factor for hospitalization. So my last slide on adults is an attributable fraction slide. And this is a study that we did a while ago. I must say, I personally used to be quite a skeptic about the role of RSV in the elderly. I used to say, well, if you find it in an elderly patient who's hospitalized, how can you be sure that the admission is as a result of the RSV? Maybe it's just the RSV season, and this is a bystander virus that you're finding in their nose, and actually the reason for admission was a bacterial or some other pathogen. But this study has convinced me. It's a study that we did, one of those healthy control studies. So where we enrolled people admitted to hospital with pneumonia and tested them for viruses, and we enrolled healthy people in the community. And then we compared the prevalence amongst admitted patients and healthy patients to look at what proportion of admissions are actually because of the virus, not just with the virus. And this, you can see that right-hand graph of severe respiratory illness shows a very strong U-shaped distribution, and really confirms that RSV, in young kids and in the elderly, if you find it overwhelmingly, it is likely that admission is attributable, that pathogen was along the causal path to that patient being admitted. It's less in the middle ages, as we might expect, but certainly in the elderly as much as in young kids. When you find RSV, it's not like a rhinovirus. If you find it, it's probably playing an important role in that patient's admission. Okay, so moving away from burden, and to talk a little bit about transmission in South Africa. And this is just a graph of seasonality of RSV in South Africa. And this is pre-pandemic data. But it's really just showing that the RSV season occurs in the first part of the year. So typically would start about February, and it should be over by now, by May. Typically, it would be over by May, although, as I'll show you later, this is an unusual year, so the RSV season is still ongoing. So it's really an autumn disease in South Africa. This is different from what you see in the Northern Hemisphere, in the US and Europe. The RSV season is in the winter, and it actually coincides with the flu season, whereas in South Africa, the RSV season is in autumn, and it comes before the flu season. And it's not really fully understood, in fact, why it is that we have a slightly different seasonality. You can see also that the season, while it's quite consistent, it does move around a little bit like flu. A lot of people think the RSV season is exactly the same each year, but you do see quite a bit of variability in terms of timing and magnitude as well. Now, I just have, as I said, this isn't so much clinically relevant, but I do think it's interesting. I've just got 3 slides here that talk a little bit about transmission of RSV in the community. So this is just to take your clinician hat off for a moment and think about when we see patients in the hospital that are admitted with RSV, they're like the tip of the iceberg in terms of the transmission of the virus, a huge amounts of transmission of the virus that is happening in the community to give rise to the patients that we actually see in hospital. And so the transmission of these respiratory viruses is something that we've been very interested in at NICD for a number of years. And the reason why we've been interested in it is because we think that in addition to actually vaccinating people directly to protect them from disease, there may be a role, particularly for influenza, but also perhaps for RSV, of trying to vaccinate the people who transmit these viruses in the community. But the first step, if you want to do that, is to really understand who's transmitting these viruses. So this is a study we did before the pandemic, 2017 and 2018. It was called the FIRST study, and it was a study aiming to really understand the burden and the transmission of influenza and RSV in South Africa. It was a cohort study, and it was conducted at a rural site, which was the Agincourt Demographic Surveillance Site, and an urban site in Clarksburg, Neil Martinson's perinatal HIV research unit site. At each site, we enrolled 50 households each year, so 50 houses, and we enrolled everyone in the house, which gave us over 1,000 people. And then we followed up everyone in the house for 10 months, taking swabs from their nose twice a week and testing all of those swabs, over 100,000 swabs, by PCR for the presence of both flu and RSV. And the purpose of that was really to try and understand the transmission, how much transmission is actually going on in the community, irrespective of symptoms, that eventually gives rise to the hospitalizations and deaths that we see. I'm not sure if you can see the figure on the right-hand side. It's a bit small, but in the bottom, that sort of gray box at the bottom, it just shows you the kind of data we got from the study. Each row is actually a person. Each column is a visit, and all the gray bars are the PCRs that were negative, and where you see the red and the blue, those are those PCRs that were positive for RSV. And what you can see is that RSV, out of the season, there's not a lot of transmission in the community, but you can clearly see the area where there's lots of green and red. That's the transmission. I mean, it may be too small for you to see, but if you see little lines under each other, those are all people in the same house spreading to one another. And if you happen to see a longer line, that's a person who shed for longer. So this is really how we visualize the transmission in the community. And as I said, I've only got 2 slides, but just to show that what we were really struck by when we did the study was how high the burden is actually of these viruses in terms of infection, both flu and RSV, in our communities in South Africa. So you can see on the top there the incidence, and just for this talk to focus on RSV, but I thought you might be interested to compare to flu. So RSV, the incidence is 47.2 per 100 person years in the community. This is overall all ages. So almost 1 in every 2 people is getting infected every year with RSV. And interestingly, 10% of people who get one infection get another infection in the same year. Those are mostly young kids with very high risk, and it's usually RSV-A and then RSV-B or the other way around. Only 1/3 of all RSV infections actually have any symptoms. So there's a lot of asymptomatic transmission happening in the community, and only 7% actually seek care at all. And the household transmission, so the risk of transmitting to household members, if you have one person in the house with RSV, approximately the chance of catching it is approximately 10%. So approximately 10% of the household members will get RSV from one infected person. And very interestingly, it's very similar for both flu and RSV. And then just to show, this is my last slide on this particular study, how that RSV in particular, just focus on the right-hand figure because we're talking about RSV today, how that breaks down by age. So that top graph, the y-axis is actually the rate of infection, and the x-axis is age group, so less than 1, 1 to 4, 5 to 12, 13 to 18, 19 to 44, 45 to 64, and over 65, the age groups. And then you can see the different bars. The blue bars are your infection, irrespective of symptoms. Your green bars are your symptomatic infection, and your red bars are your medically attended illness, which is very little. What you can see with RSV is that the rates in young kids are extremely high, 70 to 80 per 100 persons, so 80% chance per year of getting infected with RSV. Even for clinical illness, so in kids under 1, it's about 50 per 100 person season. So very, very high rates of mild disease as well, although much lower, the red bars, medically attended illness. And what you can see on those blue bars is that really going into adulthood, even into adulthood, people are being infected, with rates of about 40 or 50 per 100 person season. So you and I are probably getting infected with RSV every year or every second year. We probably don't get sick from it, but we are sort of driving the transmission in the community. And if you think of immune exposure, we're being exposed to RSV again and again and getting boosted by it. The bottom figure just shows the symptomatic fraction by age, so the proportion with symptoms by age. So the y-axis is now percentage of patients with symptoms, and your gray is asymptomatic, and then your green and your reds are different kinds of symptoms. And you can see very beautifully for RSV what we know from our understanding of severe disease, the U-shaped distribution. So if you're very young or very old, you're much more likely to become symptomatic for RSV. This, of course, is mild disease, but this is what translates into the pictures that I showed you before in the hospitals of your severe disease concentrated in extremes of life. So moving away from background and now to talk about the interventions to prevent RSV, because that's the exciting new development that's happened. And this is a very nice figure from a paper that was published last year, just showing the RSV vaccines across the life course. As I said, we tend to focus on children, and we will focus on children, but you can just see, and that's because that blue bar at the top, the burden of severe RSV is really concentrated in your infants and your older adults. And if you look at the bottom bar is your immunization strategy for different ages, you can see you've got, for that young age group, the option of passive immunization, which can either be in the form of a maternal antibody, so you vaccinate the mom, and then she passes the antibodies through the placenta to the baby, or long-acting monoclonal antibodies that you give the baby at birth, and then they last for about 6 months. So, and then you can see when we get to young children, there are a number of what they call active immunization. These are mostly live vaccines, although the other types of vaccines that are aimed at targeting children over the age of 1 year, because your passive immunity, so your maternal antibodies or your long-acting monoclonals, wear off by about 6 months. So those vaccines would be aiming to get the residual disease over the age of 1, but then also potentially to stop transmission in the community. But none of those products have come to licensure yet. And then in the elderly, there's a range of different vaccines, protein-based and other vaccines. And this slide is just to show you that it really is an extremely active field. So there is a huge interest in RSV vaccines right now, and a lot of products that are coming to market. On this figure, anything that's green is market approved. So you can see a lot of these products are not at the market. But if you look at monoclonal antibodies, there are 2 monoclonal antibodies that are market approved. One is called nirsevimab, and the other, there's palivizumab, which is the old one that many of you will know that you give every month. And then clesrovimab, which is not yet approved, but is very close, is the other long-acting monoclonal that is coming. If we look under the actual protein-based vaccines, there are 2 RSV prefusion F vaccines also that are currently licensed, and an mRNA vaccine also that's coming, but I won't talk about that. So really a busy field and lots of interventions coming. And if we just look at children, the 2 most important, because these are the licensed ones, are nirsevimab. So nirsevimab is a long-acting monoclonal antibody given to babies at birth. This product is approved by the FDA. It's licensed. It was used in a number of countries in the Northern Hemisphere for their last RSV season. These are the clinical trial data showing a very good efficacy, 74% for medically attended lower respiratory tract illness and 62% for hospitalization. And then on the right-hand side, you see the bivalent prefusion F vaccine. So this is the Pfizer product, data from the clinical trial. So this is a maternal vaccine. You give it to the mom, and it protects the baby through passive immunization, and you can see again very good efficacy there in that the right-hand side of the figure. So both of these products, very good efficacy in the clinical trials. One thing to mention about the maternal vaccine is that there were and there have been some concerns about a possible risk of preterm birth associated with the maternal vaccine. Now in the main clinical trial, the New England Journal of Medicine paper that I just showed you, the conclusion was that the adverse events were actually balanced between the 2 groups, and there was no in the overall analysis of all the countries, there wasn't a significant excess in preterm births. But when you drill into it, there was a numerical imbalance in preterm births. I mean, you can see overall it was 5.7% in the vaccinated group and 4.7% in the unvaccinated group. So not statistically different, but different. And importantly, in the South African site, which was a very big site in this trial, that it was a more marked difference. So 8.3% in the vaccine recipients and 4% in the non-vaccinated group. And so while this vaccine was a big success, there has been some concern about preterm births, and this is a slide from the FDA. The FDA were particularly concerned, and so they only registered this vaccine for later gestational ages. And I think there was some concern around this in terms of that this might make it more difficult to roll out in low and middle income countries. I'll show you a little bit later. Our regulator has now approved this product in what I think for now is a reasonable indication. And I suppose we'll need to look at more data. This could really just be a chance effect, but more data are needed to really confirm whether there is an effect. And there is actually a large clinical trial going on now in South Africa that is trying to, called the impact study, that is trying to look at whether there is this risk of preterm birth is actually real or not. I've just chosen one slide on real-world effectiveness. There are a number of studies that came out now since the last Northern Hemisphere RSV season showing that these products have a really amazing impact when they're rolled out through public health programs. This is a slide on nirsevimab, so monoclonal antibody from Spain, and it really shows the lines are all the rates of hospitalization in the previous years, and then the pink bars are what they saw so the pink bars are the left-hand side is the vaccinated group, and the right-hand side is the kids from the previous year. And you can just see how on that left-hand side, it's exponentially lower. They really just RSV was really just incredibly reduced in the vaccinated group. So where these vaccines have been used, they've been shown to have a very good effectiveness in Europe, North America, Argentina. I haven't seen it. Argentina, they haven't published it, but they've just released that on the maternal vaccine. And so these products, they really do work in the real world, but we don't yet have them in South Africa. This is just a last slide on to highlight that in kids, the potential benefit of the vaccine also does extend theoretically beyond just the prevention of hospitalizations for lower respiratory tract infection. It could translate into reduced antibiotic use because there are so many admissions, and almost all of them are getting antibiotics. It could translate into the ICUs not being so full. I think in South Africa, that's a huge impact. And there is some literature from Bangladesh, for example, showing how many kids actually die because the ICU is full and they don't get into ICU, and saying, well, if we have these vaccines, those beds will be available. And then there's also the long-term benefits, which are not proven, but in terms of recurrent LRTI, in terms of asthma and wheezing, that there's quite good evidence to show at least the association, although it's not clear to what extent RSV is causal, that there could be a lot of benefits in terms of long-term lung health as well from these vaccines, that I think we still need to wait for the longer-term data from the trials to see whether these impacts translate into reality. Adult vaccines, one slide, just to show that there is a licensed product, the RSV Prefusion F vaccine. This is the Pfizer product. Good efficacy in older adults, is approved by the FDA, has been rolled out in many high-income countries. I'm not aware, it's certainly not available in South Africa yet. There's also a GSK vaccine in adults that's also licensed, and they do work. How often you have to give them is not yet clear. They certainly provide protection into the second year, but they haven't really shown how long they last, how often you need to give them. So this is they are also coming, and if you're a geriatrician, you may see a use for these, but I'm not sure when they will be coming to South Africa. And as I mentioned, from a public health perspective, not the focus right now. So in terms of RSV vaccines for South Africa, and I always like to use this figure, which sort of shows how we think about vaccines, certainly from an NICD perspective. And for RSV, we're really sitting in the pre-vaccine stage. So the vaccines are available. They're being used in high-income countries. They're not yet available in South Africa. And we need to think, what is the evidence needed to support the introduction for South Africa? And these are the types of data that are needed. So burden of disease, seasonality, these vaccines can be given most of high-income countries, in fact, give them seasonally. They don't give them year-round. Cost of the disease and cost of the program and cost effectiveness. Also risk groups, who's at highest risk, and transmission dynamics potentially. I've shown you the slide before, but I think it's incontrovertible that South Africa has an extremely high burden of disease. Just to focus you on the numbers now. So that axis of the graph is going up to 20. It's about 15,000 per 100,000 cases of lower respiratory tract infection, severe disease in kids every year. That's massive. It's a huge, huge incidence compared to any other respiratory pathogen that we know. The burden is really very, very high in South Africa in young kids. In terms of cost, before the pandemic, we did a study to show that these hospitalizations and outpatient cases and deaths are really associated with a substantial cost to the health sector in South Africa, about $137 million each year, and most of that is incurred by the healthcare system. So the Department of Health is paying that money to treat these kids. A relatively small proportion is your indirect costs and your out-of-pocket costs, and most of that is really for the youngest kids. And that there's also a substantial burden in terms of years of life lost, over 39,000 years of life lost, estimated each year. And we did publish a cost effectiveness study before the pandemic, looking at monoclonals on the left in red and maternal vaccine on the right in blue. At that time, there wasn't, we didn't have any idea of pricing. So you can see for the monoclonals, we explored a price of between $10 and $125 per dose. And for the maternal vaccine, we explored a price of between $5 and $50 per dose. And what you can see is that the gray part shows cost saving. So because of the very, very high burden at the lowest prices, so for example, for maternal vaccine of $5 and $10 a dose, it would actually save the country money to vaccinate, because the cost is so high because of the high burden. But even at higher prices, and I don't know what price the product will come in, it certainly would be cost effective for South Africa. Obviously, when you go like above $100 for the monoclonals, that gets a bit less affordable. But I think certainly there is a case to be made for the cost effectiveness of these products in South Africa. More recently, the SAGE, so end of last year, so the WHO advisory group made a recommendation that countries should consider RSV vaccine, and they addressed this issue of the timing of the vaccine because of these concerns about preterm birth, and they've said the third trimester. And South Africa has I think the regulator in South Africa has gone with this, and the Pfizer vaccine has been approved for pregnant women from 28 to 36 weeks gestation. So this is the first approved product in South Africa. Nirsevimab is with the regulator. So it's with SAPRA. I'm not sure when we'll hear, probably towards the end of this year. And my understanding is that clesrovimab, the other long-acting monoclonal, is not far behind. And I think they may already have made submission to the regulator as well. So the monoclonals are a little bit behind, but not that far behind, and are also coming. And with that, I'm going to stop. I think there are comments in the chat, so there probably will be questions. So we can discuss more the interventions in the discussion. But just to quickly give you a surveillance update. So this is data from NICD Sentinel Surveillance. I'm sure you're almost all familiar with it. We have hospitals, Sentinel hospitals in the country, and Sentinel clinics in the country, where we have our nurses who screen everyone to see if they meet our case definition. And if they do, then we take a swab and we test it for RSV, as well as influenza, COVID, and pertussis. But I'm just showing you RSV now. And then we've been doing it for many, many years, so we have a good idea of what is expected and what is not expected. So this is RSV. We are just past what looks like just past the peak of the season. It peaked 2 weeks ago. It was a mix of RSV A and B, and it's really from all around the country. And this figure, and sorry, I actually did put flu on this figure, but the bottom left-hand graph is RSV. It's what we call a MEM graph. It's really how we grade this year's season compared to previous season. So blue is out of the season, green is low, yellow is moderate, orange is high, and red is very high. Very high is abnormal, less than 5% of seasons. It's worrying. It's something like a pandemic or something like that. And you can see the RSV season this year was high. It went up to the orange, so it was a heavy season, and I'm sure the pediatricians out there can confirm that, but it's now coming down. It looks like it's peaked. What was remarkable and unusual about this season was it was very late. It was 4 weeks later. You can see the dotted line shows historical data, or last year's data, but when we look at historical data, 4 weeks later than we've ever seen the RSV season. So I don't know why, but the RSV season was late this year. The reason I put influenza on this graph is because you can see in the black line, we are actually currently in the influenza season. And what was very strange is that the influenza season was early this year. So the influenza season was 4 weeks earlier than we've ever seen it. And as a result, we do have influenza and RSV co-circulating as we speak, which is a bit unusual and probably putting certainly the pediatric wards under a bit more burden than they would normally be seeing. This is just to show, it's not a, and sorry, just to say, this is all on our website. We publish an updated report every week, and you can easily download it. This is not published yet, but we're working on it. It's a report on the sequences that we get of RSV from our sentinel surveillance. We sequence everything that we get for flu, RSV, and SARS-CoV-2. And so we haven't published this yet, but we're working on a sequencing report that will look like this, and we'll show you the different RSV strains that are circulating. For RSV, it's not like flu or COVID that you worry about emerging variants, but once we start using the monoclonals, there is a risk that actually it's not that unlikely that they can develop a single mutation that could allow the virus to actually evade. And it has happened previously, not so much from immune pressure, but just by chance. And so we do need to monitor the RSV strains to make sure that there isn't the emergence of a strain that evades particularly the monoclonal antibodies, because they're very specific. So in conclusion, I think vaccination of pregnant women is efficacious. Sorry, it's not on the slide, but the monoclonals also are highly efficacious, and both of these really should be considered for South Africa. You know, we are where the high burden and mortality burden sits, and countries like us should be having access to these products. I didn't talk about it, something maybe we could discuss year-round versus seasonal vaccination. I think the general thinking is for the public sector, seasonal vaccination at least would be very difficult and difficult to implement. But as I mentioned, you know, potentially private seasonal might have a role, and also monoclonals, I think seasonal might have a role. In terms of, there are safety concerns giving it at a younger gestational age. So for now, we're giving the maternal vaccine in the 3rd trimester to modulate the risk of preterm birth. And really, these products are now becoming licensed in South Africa, and I suppose we urgently need to move to actually rolling them out. So with that, I will stop and take questions.
Well, thank you so much, Cheryl. Really, really amazing, and you make it sound much clearer in my head after listening to you. So thank you. That's a victory, because my head's a bit scrambled. Lots of fascinating things that came up today, and I'm just going to go through some of the chat, and some of the questions have been sent to me as well. For the first study, which again is really, to me, one of the most remarkable pieces of epidemiology we've done in the country, had that burden been seen before elsewhere described? You know, this real sort of almost 1 in every 2nd patients getting infected in a year.
So Jeremy, in fact, our study was based on a much smaller study that was done in Kenya by Patrick Muniwoki and James Noakes, who study RSV in Kenya. They did a small study for a couple of months for 1 season in Kenya, and they also found these very high rates of RSV. And so yes, in that what we found in South Africa is very similar to what they saw in Kenya, but in high-income countries, not at all. It hasn't been shown at all. And I think what is still an outstanding question is it because they haven't done the studies? Are the rates really as high in high-income countries, or is it that similar to, for example, pneumococcus? We know the carriage rates of pneumococcus much higher in Africa and to much higher ages. So is it that there's actually much more intense transmission in our setting? My sense is that there probably is a big missed burden in high-income countries, but I think there probably is some truth to the fact that it may well be we have more intensity of transmission in our setting, but because of the intensive twice-weekly sampling, there's not really been a study that I'm aware of in high-income countries, although they are now trying the once-weekly sampling. So there's a few studies coming out, but no, it's not, other than in Kenya, not described.
Interesting. And then given such a sort of high burden of recurrent infections, in my head, perhaps naively, I would have thought the maternal protection would be better. But is it, I guess, is it just because the immunity wanes so quickly, just a few months, kind of, the IgG immunity?
So I mean, so I don't know the reason for that. I agree with you. You would think because the pregnant women are exposed to such a high force of infection, they would be boosted all the time, and therefore the maternal antibodies would last longer. But it may be that on the other side of it, the children, the infants, are being exposed to such a high force of, that they're really just being bombarded with RSV from when they're born, and so even though the maternal antibodies are there, they're just not strong enough to protect them. So it's an interest. I agree with you. I also thought it would follow that way, and I don't think it's been studied. But it may just be that there's just so much RSV around that as soon as you're born, you just get exposed. I mean, and it could be something to do with how people live, perhaps that the household size is a bit bigger and there's more contact with other kids.
And I guess, I mean, if the adults are getting infected sometimes twice a year, then clearly the antibodies are not that effective, and not that long lasting. And then Halima's asking in the chat about the US cutoff of 65 years. So, I mean, I see that Pfizer vaccine's is registered and soon to launch. Is SAPRA only recommending it for the younger age group, or can it be used for the older age group too?
Actually, I'm not. I've been so focused on kids. I realized just when I was coming in for the talk that I actually don't know if SAPRA's I don't know if the company actually applied for registration in adults. I think maybe not, but somebody else may know. Regarding the 65 years, I think it's a risk benefit, right? So you saw how exponential the increase is with increasing age, and so the cost of the vaccine versus the risk of severe disease, it's a trade-off, and they've chosen to cut it at 65. Whether that's right or it's relatively arbitrary. I mean, they could have gone for 60 or they could have gone for 70. For South Africa, I think it is an interesting question, though, because one of the reasons RSV in the elderly is just not so much of an issue is our life expectancy is so low. And so if we were to introduce them, what age we should be thinking of, I think is something we need to discuss. Certainly for COVID vaccines, they sort of talk about giving them a bit younger at 50 in countries like ours. But I do think it is really in adults, it's really people who are older and have underlying illnesses. Healthy adults really don't end up in hospital with RSV typically. So I think even in South Africa, you're going to get your bang for your buck in the older patients with underlying illness.
So a couple of people in the chat. Sorry, I think when I was asking you the question, I said, for children. Clearly, I meant for pregnant women, for the children passively, but sorry, not directly for the children. Absolutely.
Of course.
And I see some people have said it is registered for. Sorry, I'm looking. Sorry, through the chat. It's bouncing up.
Elderly and pregnancy, so she must know that well, being an adult physician.
And then a question about the timing in pregnancy. I guess it's a trade-off between the risk of preterm labor, if that's a real risk, right? Because you're saying that isn't it a bit late in the third trimester, you might not get a good antibody response.
Absolutely. So I think we would have preferred to be able to give it earlier, right? And also in South Africa, from a programmatic perspective, I think you really want to give it when the woman is there, and if she's there, you should be able to give it, not have to say, well, come back, and when you come back, I'm going to give it to you. So I think it's not ideal, the third trimester, both because it gives you less time for the antibodies to develop, and of course, that's a problem because your preterm babies are the ones at highest risk of severe outcomes. But I think there is a concern about this preterm birth risk. My feeling is it probably is just either an artifact of COVID or chance. But I think regulators are being cautious because, of course, if it is a real risk, well, that is very consequential. And in fact, there was a modeling study done when the SAGE made their recommendations. One of the most important pieces of information they considered was a modeling study parameterized with South African data, which really looked at if the signal on preterm birth were true, would the mortality impact be more on the negative side than the positive side for South Africa using our data? And what it showed is that before 28 weeks, it would actually result in more deaths. And so I think the 28 weeks is really quite evidence-based for South Africa, in fact. If the signal were true, which it probably isn't, and I think we just need to wait, hopefully with time and more data accumulating, we'll be able to move that earlier, because I do think programmatically it's not ideal. And you're right about the issue. And that's why I think in South Africa, it's never going to be just the maternal vaccine. We do need to think about monoclonals because there will always be kids who are born too early. They haven't had time or that missed the maternal vaccine and who would need to be mopped up with monoclonals.
Yeah. Fakila Mabena, one of the pediatricians, is also making a really good point about the teenage pregnancy, given that this vaccine will only be registered for people 18 and up. I guess that's another potential miss, in terms of group who would want to catch.
Yeah, absolutely, absolutely.
And then a question about surveillance from Judy, one of our from
that's a great
asking,
question. Yeah,
he's asking about what about the weekend data we miss.
So Judy, you're absolutely right. We do only enroll the patients during the week. We don't enroll patients on the weekend. And so we don't test those patients on the weekend. I think again, it's a trade-off, right? In this case, it's a trade-off between our resources to be able to have our staff come in on the weekends versus sampling during the week. But the surveillance really, already it's only at a few hospitals throughout the country. So the purpose of it is really to understand the general trends within South Africa, and that's really the timing of the season, when it starts, when it ends, when it peaks, how bad is it, and are the strains changing at all? And then other questions, like you saw all that risk factor data, the burden data, that all comes out of our surveillance as well. So that's additional analyses. In order to do that, as long as we think that the pattern of viruses on the weekends is not substantially different from during the week, it's probably not such a loss. And we do collect the number of admissions over the weekend. So when, for example, we do our burden estimates, our incidence, we do account for that, and we do sort of fill in the weekend so that we don't underestimate. So I think it does. I personally don't feel that it undermines the validity of the conclusions that we make in terms of burden, in terms of timing, in terms of circulating strains, in terms of risk factors. Although it would be nice, and sometimes when we do special studies, we do get additional resources for over the weekend. But I don't think it compromises the validity of the surveillance.
Yeah, I agreed. And then there's a question from, I think, Nosisa, also asking about the HIV risk factors. So she was mentioning in the case of flu, saying in first there wasn't much of an association apparently between people living with HIV and I'm not sure if hospitalizations or burden. And they're saying that maybe that's because they're well controlled and on antiretroviral therapy versus other earlier studies. Is the same sort of phenomenon seen with RSV as well? Like, does it depend if you're on ARVs?
So it's really interesting. I think there's two different there's different parts to it. Okay, the one is the HIV, the treatment question. And I think absolutely what we've seen is that people living with HIV who are on treatment, a very large part of the elevated risk of severe disease goes away, but not completely though. So your risk might go from 20 times greater to 2 times greater or 4 times greater. And when we look at things like shedding, so if we think about the role of people living with HIV in transmission of these viruses, shedding, it's almost complete. So people living with HIV who are not on treatment will shed viruses for much longer, and this allows transmission. But people on treatment, there's really not a difference, in fact. So that's part of the story. But I think another part of the story is that it's, one thing we always knew that people living with HIV had a higher risk of hospitalization and mortality for multiple respiratory pathogens. But it wasn't clear whether that was because they were at higher risk of getting infected or at higher risk of, once they were infected, going on to develop more severe disease. And I think if you take together all the studies we've done, it seems that it's much more likely the latter. So the risk of infection is not really, it's not about infection. It's that once you're infected, your immune system can't control the virus, and so you go on to become hospitalized and then have a higher risk of mortality. So in that way, HIV, I think, is I suppose it's not so much like age, but so it seems that when you go to the mild disease, there isn't such a differential by HIV. It's really that once you're infected, then you're just much more likely to end up in hospital or die.
Interesting. Yeah. I see I got a comment from someone saying that the private price, at least for the Pfizer vaccine, is likely to be 3,000 Rand per dose, which makes me cringe inside a little bit. Not sure what that's going to do for the state price, but we'll see. But look, I mean, it's really, as you said, it's exciting because this is, it's a real big mover. And I mean, just again, semi-anecdotally, we worked a bit with Sibongile from your lab, in NICD, looking at RSV a little bit at Helen Joseph for small med, but even with that, it suggested it for us in adults. It's still, as you rightly said, although it's rare in terms of numbers, it is a significant contributor to disease, and in fact was totally unrecognized by the clinicians, and presented in odd ways. It didn't present as a pneumonia type thing. It often presented with exacerbation of COPD or exacerbation of cardiac failure. Again, well described in the literature, but just not a thing that people think of. And so down the line, maybe even for adults, but agreed. I mean, you made point entirely well made that this is really, to a first approximation, if you squint a little bit, just a disease of kids.
No, absolutely, and I think, and if you find it in adults, though, it is attributable. That's what we.
Yes.
So it is causative. There's actually an MEd. There's a from Cape Town. I don't know if she's published it, but an adult physician also has done a case series. And you're right. They completely missed, undescribed, and a lot of in fact HIV. So a lot of those adults with RSV, we do see elderly and underlying illness, but in South Africa, I think a lot of patients with RSV also have HIV. So it may have a place. It's just not at this point for the government to pay for it.
Absolutely, yeah.
And then I agree, the cost is hopefully will be much less for the state.
Yes.
Right.
Yeah. Otherwise, we'll be talking about it in 5 years' time still. Okay, but thank you so much again. We're pretty much out of time, but it's again, Cheryl, such a great talk, and really appreciate it. Over 200 people in the audience today, so really, you clearly have drawn the crowds. So thank you very much for making it simple for us. Appreciate it.
Thanks for having me.
Cool. Thanks.